This is a continuation of the series of the anatomy videos, and this session will be about the anterior abdominal wall. That is the part 1, the anterior abdominal wall. Here is the thickness of the area, which you call it anterior abdominal wall, from the skin to the parietal peritoneum of the peritoneal sac, which starts from the skin, the superficial fascia, which divides into two layers, a fatty layer and a deep membranous layer. As for the deep fascia, either absent, considered absent, or if it is there, it is a very thin layer attached to the external oblique aponeurosis, so it is not there. And this to allow the extension of the anterior abdominal wall during pregnancy, during full meals, and other accidents. That is the three layers now: the external oblique, the internal oblique, and the transverse abdominis, and the three muscle layers of the anterior abdominal wall, followed by the fascia transversalis deep to them, and then lastly, or before last, that is the extraperitoneal fatty tissue, and then the parietal layer of the peritoneum. That is the thickness of the anterior abdominal wall. When it comes to the deep membranous layer, if you have a section at the middle line, so that is the skin here, and this is the fatty layer, that is in blue, the membranous layer, which will extend in the genital organs to be the superficial penile fascia of the penis or clitoris. If you go a bit lateral in male, this will be the scrotum, and the extension of the deep membranous layer will form what we call it the dartus muscle. Lastly, more lateral, that is the external oblique aponeurosis, which will form the inguinal ligament. We'll find that the deep fascia of the thigh and the deep membranous layer will end down below the inguinal ligament for about 1 inch to fuse with the fascia lata. That is the position of the deep membranous in the anterior abdominal wall. Now, the important point about the dermatomes of the anterior abdominal wall, which reflects the referred pain if anything inside the cavity. At the zivisternal, this is the 7th, the 8th, the 9th. At the umbilical region, there's number 10. Any pain around that may be related to the appendix, and then that is the 11th. And the suprapubic region will be by the subcostal nerve. Below that, which go to the scrotum and that area, is the first lumbar segment. So this is the dermatomes of the skin of the anterior abdominal wall. While the cutaneous innervation of the anterior abdominal wall can be divided into two groups. The anterior group will be the lower 5 intercostal. The tense nerve supply the area around the umbilicus, as we said before. The suprapubic will be by number 12, while the lateral group will be the lower 3 intercostal nerves, the subcostal nerve, the iliohypogastric, and the ilioinguinal. What we can see here, that is the 8th, the 9th, the 10th, the 11th, and the subcostal nerve reaching the suprapubic region. That is the anterior branch of the iliohypogastric, and that is the position of the ilioinguinal, which reaches the middle line. Those are the cutaneous nerves of the anterior abdominal wall. When it comes to these cutaneous nerves in a cadaveric specimen here, we can see those are the nerves here, which starts from the branches from the intercostal nerve, the 9th, then that is the 10th, that is the 11th, that is the subcostal, that is the iliohypogastric, and that is the transverse abdominis in the most anterior part of the anterior abdominal wall, where we or this one is demonstrated within that muscle, the transverse abdominis muscle here. Now, the cutaneous blood supply and lymphatic drainage of the anterior abdominal wall will start by the arteries, which from above, the lower 5 intercostal arteries which join their nerves, and the subcostal artery again with the subcostal nerve, and those arise from the thoracic aorta. From below, it receives from 3 arteries: superficial externopudendal, that is the one over here going to the medial side and to the genital organs. That is the superficial epigastric toward the umbilical region. That is the superficial circumflex going toward the anterior superior spine. And there is some branches which comes from the 4 deep arteries of the anterior abdominal wall. That is the cutaneous supply, arterial supply. When it comes to the veins will accompany the arteries and terminates into those upper veins will end in the azygos vein, which will end in the superior vena cava, while inferiorly into the great saphenous vein, which end in the femoral vein, and then lastly to reach the inferior vena cava. So this connects the superior with the inferior vena cava in case of any blockage. That will be the way for the venous return. The lymphatic vessels of the anterior abdominal wall, there are plenty lymph vessels which present in that superficial fascia. Those above the umbilical region or above the umbilicus will drain into the axillary lymph nodes. Those around the umbilical, below the umbilicus, will drain into the inguinal nodes, and that is the what we call it the watershed between the upper and the lower lymph vessels. But the lymphatics around the umbilicus itself will pass through the falciform ligament around the ligamentum teres of the liver to reach the nodes present in the porta hepatis. That is the lymphatic drainage of the superficial fascia of the anterior abdominal wall. Now we come to the 3 muscles. The external oblique muscle, the first layer of muscles, which takes origin from the external surfaces and lower borders of the lower atrips, which interdigitate with the latissimus dorsi, that is the digitations of the latissimus dorsi here below, and with the serratus anterior also. So it interdigitate with the serratus anterior and the latissimus dorsi. Latissimus dorsi from the lower 4 ribs, and the serratus anterior from the upper 8 ribs. The insertion, the fibers divides into 3 types or 3 groups. Those from the lower 2 ribs are fleshy or are flesh, which pass vertically downwards to be attached to the outer lip of the anterior segment of the iliac crest. It descends vertically. They share in the boundaries of the lumbar triangle, which we'll show later. That is the vertical parts of the external oblique. The middle and the upper fibers will terminate into an aponeurosis, which decussate with the other side, forming the linea alba. The inguinal ligament, which is a part of the external oblique, is the thick enrolled lower border of the aponeurosis of the external oblique and stretches from the anterior superior spine up to the pubic tubercle medially. Its grooved abdominal surface forms the floor of the inguinal ligament, inguinal canal. At its lower border, it is continuous with the fascia lata of the lower limb. The inguinal ligament again, which is a very important structure here, which separates the thigh from the anterior abdominal wall, that is the inguinal ligament. Its medial end some fibers extend in two directions. Some expand posteriorly and laterally to attach to the pectineal line, forming what we call it the lacunar ligament. That is the appearance of the lacunar ligament, a lateral extension of the medial end of the inguinal ligament on the pectineal line. The other fibers pass upwards and medially behind the superficial inguinal ring and behind the cord, and extend oblique to join the rectus sheath and the linea alba. This is the reflected part of the inguinal ligament. That is the part here which is behind the spermatic cord and behind the superficial inguinal ring. That is the superficial inguinal ring over here and over here. That is the spermatic cord coming out from that ring and here on both sides in that diagram and this cadaveric specimen. That's what we call it the intercrural fibers, which connect to the linea alba between the two crura on both sides, and this will help in keeping that opening, preventing the dilatation of such opening, the superficial ring. And that is the reflected ligament, which, as we said, is the lateral extension going to be attached to the linea alba. And that is the linea alba on that side, and that is the other side of the linea alba on the diagram. The anterior fibers which form the anterior and middle fibers, that is the aponeurotic fibers here. So these are the fleshy and these are the aponeurotic fibers. Still with the external oblique, the innervation will be the terminal branches of the lower 5 intercostal nerves, the subcostal nerve, and the ventral rami of the lower 6 thoracic. These are the lower 6 spinal nerves. The action is contribution to the maintenance of abdominal tone, increasing the intra-abdominal pressure with the other muscles, lateral flexion of the trunk against resistance. That is what we call it the lumbar triangle here. That is the lumbar triangle, which is bounded by the external oblique, the vertical fibers of the external oblique, and the latissimus dorsi posteriorly. The floor is formed by the internal oblique, and the base is formed by the iliac crest. Now for the internal oblique, the second muscle, that is the internal oblique here, and as you can see, that is the cut edge of the external oblique, so the ribs are not covered. The origin, the muscle takes origin from the lateral 2/3 of the inguinal ligament, from the anterior 2/3 of the intermediate line of the iliac crest, and from the middle layer of the thoracolumbar fascia. As you notice, the external oblique comes from above, downwards. That muscle comes from below, upwards. The transversus will come from above and down and go horizontally. So that is the part of the fascia here, the middle layer of the thoracolumbar fascia. And that is the cut edge of the external oblique here and here. Still, the insertion of that muscle, the posterior fibers runs upwards and laterally to the inferior border of the lower 3 or 4 ribs. That is the posterior fibers. Its upper part is attached to the 7th, 8th, and 9th costal cartilages. That is the part attached to the costal cartilages here and here. The middle ends in an aponeurosis. The upper 2/3 of that aponeurosis splits into 2 layers, anterior and posterior to the internal oblique, while the anterior part will fuse with the external, while the posterior part will fuse with the transverse abdominis. Above, that is down to the anterior lamina fuse, as we said, with the external oblique, the posterior with the transverse abdominis, but in a midway between the umbilical region and the symphysis pubis, all the three muscles will be passing fusion together in front of the rectus abdominis. That is the lower part here. The insertion of the anterior oblique, the lower fibers which arise from the inguinal ligament, and these are very important fibers here. These are the ones here and here. Those pass upwards and medially in front of the spermatic cord, then curve backward to become posterior to the spermatic cord. That is what we call the triple relation of the lower fibers. Being posterior to the spermatic cord, it fuses with the transverse abdominis tendon to form what we call it the conjoined tendon or the falx inguinalis. This is attached to the pubic crest and the pectineal line. These are the fibers which will form what we will call it the shutter mechanism for the inguinal canal. Due to the triple relation of that muscle with the spermatic cord, it forms what we call it the shutter mechanism as it shuts the canal during the movement, which increase the intra-abdominal pressure, preventing herniation. That's important fibers of the internal oblique. The nerve supply of that muscle is almost like the transversus, but you add to them the iliohypogastric and the ilioinguinal. Still with the internal oblique here, this is a cadaveric picture for the lower part of the anterior abdominal wall, showing the spermatic cord and the inguinal canal with the arching fibers of the internal oblique. That is the same diagram which you have seen in the previous slide. So that is the arching fibers of the anterior oblique, and that is the fleshy one on the cadaver. That is the cremasteric muscle which arises from the internal oblique. That is the ilioinguinal nerve, which is one of the contents of that inguinal canal. And that is the spermatic cord. The one which you can see a cut edge here, this is the external spermatic fascia, which comes from the aponeurosis of the external oblique from the sides of the superficial inguinal ring. Now, from the internal oblique, there is a muscle which called the cremasteric muscle, which arises from the inner surface of that internal oblique muscle. It forms a spiral loop around the cord, which unites with the fascia, so it forms the cremasteric muscle and the fascia at the second cover or the middle cover of the spermatic cord. That is the fibers of the cremasteric muscle shown on a cadaver here. The insertion of that muscle divides into two. The short fibers go direct to the pubic tubercle, while the long ones will be around the tunica vaginalis of the testis and back to be attached in the pubic tubercle. That's why in cremasteric reflex it can raise the testis up. It's supplied by the genital branch, that muscle, the cremasteric, by the genital branch of the genitofemoral nerve. Now the last muscle of the layers of the anterior abdominal wall, the transverse abdominis, this one shown here and here. The muscle takes origin, as we said, from below and upwards, and in the middle, the lateral 1/3 of the inguinal ligament, the anterior 2/3 of the inner lip of the iliac crest. The thoracolumbar fascia will be around here, and the internal aspect of the lower 6 costal cartilages. That is the origin of that muscle. This coming from the inner surface of the lower 6 costal cartilages. So it does not go above the costal margin, exactly like that of the internal oblique. It does not go above the costal margin. Now, the insertion, most of the muscle ends in an aponeurosis. Here you can see that aponeurosis here and here, which pass horizontally. Its upper 3 forces, it fuses with the posterior lamina of the internal oblique, as we said, but the lower force will pass in front of the rectus with the other muscles. The upper muscular fibers of the transversus will pass medially behind the rectus 2 or 3 centimeters below the xiphoid process to be inserted into those ribs. The lower fibers of the muscle form from the inguinal ligament and as aponeurosis, as we said, to fuse with that of the anterior oblique to form the conjoint tendon. Still with the transversus abdominis, that is the transversus abdominis here. That is the internal oblique here. That is the fascia transversalis over here. And of course, this is the external oblique. That is to show the union of part of the anterior oblique with the transversus abdominis to form the conjoint tendon. That is the spermatic cord, and that is the conjoint tendon, which will pass deep to the spermatic cord. That is the 3 layers together, as shown in the previous slide, showing the transversus abdominis, the superior gastric vessels here, which will be discussed later, the linea alba, this one here, the parietal peritoneum on this side. All the anterior layer have been removed to show the deep, which is the parietal layer. The fascia transversalis have been removed. The extraabdominal fatty tissue have been removed. The bladder in the middle line here with the median umbilical ligament. That is the spermatic cord here. And that is the external oblique cut. That is the internal oblique. And that is the arcuate line, which will be discussed with the rectus abdominis. That's a good cadaveric dissected specimen, which show most of the anterior wall. This is the inferior epigastric arteries. That's a collection of all the 3 muscles which have been seen before. You can see the external oblique, which is the only one above the costal margin, then the internal oblique, which is above the costal margin. The transversus abdominis, again, does not pass. This is the anterior oblique here. It's stopped by inserting into the lower 6 costal cartilage. The transversus abdominis will be taking origin from these 6 costal cartilages. That is the arrangement of the 3 layers, as we have seen it also in the cadaver. That is the external, internal, and transversus abdominis. That is the external, that is the internal, and that is the transversus abdominis. And this will end up with the muscles of the anterior abdominal wall, the 3 layers. And the next session will be the rectus abdominis and in its sheath. Thank you.